Hello everyone. Today I'll be presenting Anomalous but not Anonymous, recognizing Mullerian variants in daily practice. I'm Dr. Gouri Vinod Pillai and I'm presenting this work under the guidance of Dr. Madan Manmohan and Dr. Sanjay Pasoria from Dr. Deepak Patkar University. Mullerian anomalies are more common than we think, affecting around 5 to 7% of the general population and up to 25% women with recurrent pregnancy loss. These anomalies have significant clinical implications, including infertility, recurrent pregnancy loss, preterm delivery, and malpresentation. Notably, the subseptate uterus has a 60 to 80% pregnancy loss rate, with biconjugate uterus leading to preterm delivery in around 15 to 25% of cases. Our role as radiologists is crucial in detection, accurate classification, and guiding the appropriate management. Coming to the classification, the key differentiator is the external fundal contour. A septate uterus has a fundal contour of less than 1 centimeter indentation, while a biconjugate uterus shows a deeper cleft which is greater than 1 centimeter. This distinction is critical because the surgical approach is completely different, with a septate uterus requiring hysteroscopic metroplasty, while a biconjugate uterus typically requires no intervention. The ultrasound is our first-line modality, with transvaginal scanning providing excellent uterine details, especially where 3D coronal plane is available, which is the gold standard. We can assess the fundal contour, the endometrial configuration, as well as the cervical anatomy. MRI serves as a problem solver for complex anatomy, such as obstructive anomalies which require surgical planning, as well as tissue characterization. We always need to remember that USG and MRI are partners, not competitors. Coming to our first case, the subtle separator. Our first case is that of a 29-year-old P2L1D1A1 with 2 previous pregnancies, 1 live birth, 1 demise, and 1 abortion. She presented with spotting and abdominal pain following a DNC for a second trimester spontaneous abortion. Ultrasound revealed a heterogeneously hyperechoic mass in the endometrial cavity with internal vascularity on color Doppler. The critical finding on 3D imaging was a fundal indentation, which was less than 1 centimeter, and an incomplete septum, which was extending into the cavity, which is diagnostic of a subseptate uterus. We also identified retained products of conception. MRI confirmed the subseptate uterus, showing the T2 hypointense fibrous septum. It better characterized the extent of RPOC, with a small area which was enhancing on post-contrast images, which was valuable for pre-surgical planning. The clinical implication here is crucial. The subseptate uterus has the highest association with pregnancy loss amongst all Mullerian anomalies, around 60 to 80%, due to a decreased endometrial receptivity, abnormal implantation, and compromised blood supply. The take-home message here is to always look for uterine anomalies, especially in patients with recurrent pregnancy loss. Coming to our second case, an early hope and an unusual hope. Case 2 is that of a 30-year-old prime gravida who was 6 weeks 5 days by LMP, who came for a routine early obstetric scan after a positive pregnancy test. Transvaginal ultrasound showed a deep fundal cleft, which was greater than 1 centimeter, immediately suggesting biconjugate uterus. We identified a single live intrauterine pregnancy in the right horn with appropriate cardiac activity, while the left horn showed decidualized endometrium as shown in the 4th image. For biconjugate uterus, the risks include 15 to 20% preterm labor, 25 to 40% malpresentation, and 20 to 28% fetal loss. Our role as radiologists is the early documentation of the anatomy, communication with the obstetrician, and establishing high-risk pregnancy monitoring with serial growth scans and cervical length surveillance. The key point here is that no surgery is needed for biconjugate uterus. Management is expectant with enhanced surveillance. Coming to our third case, the third trimester triumph, case 3 demonstrates a successful pregnancy outcome. This 28-year-old female in her second pregnancy came for a routine scanning and ultrasound showed a biconjugate uterus with the gravid left horn and a viable fetus at 34 weeks in breech presentation. Here, the important clinical pearls are to know the anatomy early. We shouldn't mistake the empty decidualized horn for a mass, as seen in this first image. We should expect malpresentation and assess growth carefully due to reduced cavity volume and plan for delivery. Cesarean rates are higher in these cases. Uterine anomalies should be clearly documented for the surgical team. Coming to our last case, the silent emergency. Our fourth case is the most urgent. A 15-year-old presented with cyclical lower abdominal pain for 5 months and primary amenorrhea. She is a known case of horseshoe kidney with past surgical history of imperforate anus repair and sigmoid vaginoplasty. Ultrasound reveals two severely divergent uterine horns, with the left horn markedly enlarged and containing fluid with a debris level as seen in this image, which is highly suspicious for hematometra. We also identified a left-sided hydrosalpinx/hematosalpinx, and the right horn appeared normal as seen in this image. MRI was invaluable here, confirming our hematometra with a characteristic T1 hyperintense and T2 hypointense signal. It showed no cervix-like structure as seen in this image and confirmed the left hematosalpinx as seen in this image. This detailed the cervico-vaginal anatomy, which is crucial for surgical planning. Why is this an urgency? Delayed diagnosis leads to devastating consequences. Within 1 to 3 months, hematometra will develop. By 3 to 6 months, hematosalpinx can occur because of the retrograde menstruation. And within 6 to 12 months, endometriosis and adhesions can form. After a few years, severe endometriosis may necessitate hysterectomy, which will destroy the fertility potential. This patient also demonstrates the important association with renal anomalies, which are present in around 30% of the cases. The take-home message here is that primary amenorrhea with cyclical pain equals obstructive anomaly unless proven otherwise. This requires urgent gynecological referral and cannot be managed medically. To summarize, these 4 cases represent the spectrum of Mullerian anomalies. Subseptate with a pregnancy loss requiring hysteroscopic treatment, early pregnancy in a biconjugate needing high-risk monitoring, third trimester success with delivery planning, and an obstructive emergency which requires urgent surgical intervention. One lesson unites them all. Accurate imaging changes management. This is a practical ultrasound checklist which shows that we should assess the fundal contour, the endometrial cavity, the cervix, the vagina, the associated findings, and Doppler in all cases that we're suspecting a Mullerian anomaly in. And we should always use MRI strategically when the ultrasound is inconclusive, especially for obstructive anomalies which require surgical planning, for tissue characterization, or when assessing hematometra and suspected endometriosis. The classification pitfalls that we need to be aware of are to differentiate between arcuate and subseptate uterus, since both have a fundal indentation of less than 1 centimeter, biconjugate versus septate uterus, where the external contour is key and the 3D coronal plane is essential, biconjugate versus diadelphys, which is dependent on the number of cervices. And in cases of a pregnancy in a biconjugate uterus, we should always remember the empty horn may mimic a mass and we should fall out of that trap. The take-home message would be the 3 R's. Number 1, to recognize these anomalies by maintaining a high suspicion and using 3D coronal views whenever available. We should refine our diagnosis using ultrasound as a first line and MRI as a problem solver. And thirdly, we should relate our imaging to clinical outcomes, since our diagnosis changes the patient care. The bonus R here would be to always remember the kidneys. Whenever there's a Mullerian anomaly, always check out the kidneys. A final thought. From first trimester hope to third trimester success to life-threatening emergencies. Mullerian anomalies aren't just anatomical curiosities, they're clinical challenges where our imaging makes the difference. Thank you.